And welcome back. So we'll pick up the story now with nutritional factors that influence risk of osteoporosis and help in its management, actually. So we'll start with the obvious one, which is calcium. So calcium is the major component of mineralized tissue, and it's required for normal growth and development of the skeleton and, of course, the teeth as well. So calcium accumulation in bone during pre-adolescence is between 140 and 165 milligrams per day. But during the pubescent growth spurt from age 11 or age 12 to age 20 up to age 24, an individual can accumulate 400 to 500 milligrams a day of bone accretion if they have optimal intake of calcium during those years. So in this stage of life, the fractional intestinal absorption of calcium is very efficient and estimated to be approximately 40%. That means of all the calcium a person ingests during those teenage years, from food and or supplements, about 40% of it is getting absorbed into the bloodstream and can be used to actually increase bone mineral density. So understand that means 60% doesn't get absorbed and stays in the intestinal tract, but it's serving an important role there as well by binding to bile acids and preventing the conversion of bile acids into secondary sterols that are linked to the development of colon cancer. Now, as you get older, you're absorbing maybe 30 to 35% of the calcium that you're getting from food and or supplements. But during that pubescent growth spurt, the individual can absorb 40% of all the calcium that goes into their body. It's a significant amount. So peak adult bone mass is largely achieved by 20 years of age in women, although further gains can occur until age 30, but more so in men. So we'll keep going. So recent evidence suggests that adding 500 to 1,000 milligrams a day to the current calcium intake may increase bone accretion rates in pre and adolescent boys and girls. So individuals 11 to 24 years old, the thinking is we should be giving them more calcium than we previously thought was the case. So the National Institutes of Health, this was in 1994, raised its calcium recommendation for this particular age group to 1,200 to 1,500 milligrams per day for individuals 11 to 24 years of age. It used to be significantly lower than that, around 700, 800 milligrams. Presently, the average calcium intake in that age group is about 900 milligrams a day. It's not bad, but it's probably because they're eating a lot of pizza and I guess they're drinking milk, but they're getting 900 milligrams a day on average, which is not bad. So they're probably missing, maybe 500 milligrams a day that would really be beneficial to them and help to give them optimal bone density by the time they get to the early 20s of their life. So the National Institutes of Health in 1994 published this in the Journal of the American Medical Association. They talked about what they felt was optimal calcium intake. So this is what it looks like for different age groups, and I really like this particular model of calcium intake. These values, to me, it really resonates with where I see the research support has come from. So, children or infants, under 6 months old, 400 milligrams, up to 1 year, 600 milligrams, from 400 to 600 milligrams, you see that up to a year old. Then from ages 1 to 10, 800 milligrams a day. And then boys and girls, if you want to call them that, from age 11 to 24, 1,200 to 1,500 milligrams a day. Remember, most are only getting about 900. And then from age 25 to 50, 1,000 milligrams is probably adequate. But then for postmenopausal women who are not on hormone replacement therapy, they need to get to 1,500 milligrams a day. And for postmenopausal women who are taking estrogen replacement therapy, because estrogen is helping to keep calcium in bone, they probably only need 1,000 milligrams a day from food and supplements. And then 65 years an older and a postmenopausal woman, whether or not she's taking hormone replacement therapy, once she's over 65, no matter whether she's using hormone replacement therapy or not, she should be aiming for 1,500 milligrams a day. And in men who are 50 to 64 years old, probably 1,000 milligrams a day is adequate, especially if they're active. But once you're over 65 years old and you're a male, 1,500 milligrams a day should be your new target to prevent osteoporosis as a person becomes elderly. I really like these values. I think that they are sort of the targets you might want to keep in mind. So those preceding values are the most recent calcium recommendations outlined by the National Institutes of Health for the American population, who tend to have, and this is an important phrase here, a high animal protein diet. So these calcium values, they sound pretty high, and that's because you need more calcium ingestion when you're eating more animal protein foods. Animal protein foods tend to increase the levels of sulfuric acid and acidify the blood, and so to maintain the normal pH value of the blood, calcium will be borrowed from bone to help act as a buffering system. And so we lose more calcium from bone when we have high protein diets from animal protein, as happens in much of the developed world. Much of the world in North America eats this way. But in societies where they're consuming less animal protein, they're getting the protein from beans and peas and soy products, and it's more plant-based, and they get a little bit of meat and a little bit of fish, then they can maintain more optimal calcium bone status without having the high calcium recommendations that you saw in the previous slide. So it really has to be personalized a little bit. Thus, a person's absolute calcium need must factor in a number of variables, such as their animal protein intake, and then we'll see that caffeine washes calcium out, alcohol depletes calcium. If you're exercising, you're helping to maintain calcium and drive calcium into bone. Family history of osteoporosis, what's the blood level of vitamin D, what's the parathyroid hormone status, what about use of other drugs like corticosteroid drugs and Dilantin, and possibly their risk profile for colon cancer. If there's an increased risk of colon cancer, then you want them on higher calcium to help reduce that risk of colon cancer, not just to support their bone density. And also for high blood pressure, more calcium helps to bring blood pressure down as well. We saw that in the cardiovascular subject matter. So knowledge of these and other related factors should help to place the preceding guidelines into a proper perspective. Because there are places in the world where societies are getting 500 to 700 milligrams a day of calcium, but they don't have a lot of osteoporosis problems. But these are typically places in the world where individuals are working outdoors most of the time. They're getting a lot of sunlight, their vitamin D levels are higher all the time, and they're doing laborious physical activity work, which helps to keep calcium in bone, and they're not eating super high animal protein diets, more plant-based, a little bit of meat, a little bit of fish, but a lot of the calories coming from plants. And in those societies, they don't need to have 1,000 and 1,500 milligrams of calcium a day. But the way people live in North America, that seems to be what's required if they're following a more traditional North American lifestyle. So we'll look at calcium absorption, toxicity, and the upper limit of safety. So the efficiency of calcium absorption decreases as intake increases. So as you start putting more and more calcium into your body on a daily basis, the amount that gets absorbed after a certain threshold starts to become less. So the body has a protective mechanism to try to protect absorption of calcium into the body, so you guard against calcium toxicity. But this adaptive mechanism can be overcome by a calcium intake of over 4,000 milligrams a day. There's never a reason for a person to be getting 4,000 milligrams of calcium a day. That can get them into trouble with soft tissue calcification in particular. So it's generally acknowledged that the safe upper limit of calcium intake between food and supplements is about 2,000 milligrams a day. No need for it to be higher. So having an understanding of the person's dietary intake patterns first helps you decide whether or not you want to give them calcium. They might be having, 2 large containers a day of yogurt, which would put them already at 2,000 milligrams a day easily. So giving them additional calcium beyond that might actually be detrimental. So you have to have a snapshot of their behavior patterns first. Then there was this really sensational review paper in the American Journal of Clinical Nutrition in 2005. And there really hasn't been a great one like this since. And this is, I'm recording this now in the year 2018. So here's what they say with respect to calcium and vitamin D. A deficiency of either calcium or vitamin D will result in reduced calcium absorption and a lower concentration of circulating ionized calcium. When this occurs, parathyroid hormone secretion is stimulated, and then there's a resulting increase in parathyroid hormone levels, and the cumulative effect of higher parathyroid hormone levels, secondary to poor calcium or vitamin D nutrition, is an increase in bone remodeling, leading to significant loss of bone and an increased risk of fracture. So when there's not enough calcium and or vitamin D, and blood calcium levels are starting to decline, parathyroid hormone will borrow that calcium from bone to maintain normal calcium levels in the blood, and the bone remodeling occurs in a way that decreases bone mineral density and changes the architecture of the bone, putting you at greater risk for a fracture. In the review paper, it goes on to say this about calcium. The average U.S. diet contains only 600 milligrams of calcium a day and falls far below the recommended intake levels. So that's the average intake, about 600 milligrams. If an adequate calcium intake is not possible in the diet, a calcium supplement may be required and should optimally be taken in doses of at or around 500 milligrams at a time to maximize absorption. In other words, if you put 1,000 milligrams of calcium in your body at one time, the first 500 milligrams are going to get absorbed at a nice rate, maybe 30 to 40%. But the second 500 milligrams beyond that, you're probably going to get minimal absorption. So you want to stage calcium supplementation in, not putting in doses of more than 500 milligrams at any given time if you're going to use supplements. The preferred time to take those supplements is with meals, not on an empty stomach, not late at night to try to help you sleep better, taking calcium on an empty stomach. It's because calcium is absorbed much better with other constituents of food. And also that calcium, when it gets absorbed, is going to help to the kidneys excrete more sodium so your blood pressure doesn't go up. And that calcium at meals is going to help to bind to bile acids in the large intestine to prevent the conversion of bile acids into secondary sterols that are known to cause colon cancer. So to prevent colon cancer as well, you want that calcium at a meal. But for bones, that calcium at a meal is going to be absorbed better and have a better chance to increase bone mineral density for you. And calcium carbonate has more calcium per tablet than most other forms of calcium, such as calcium citrate. So when you look at 2 calcium tablets that are the same size, because you can only make tablets up to a maximum size before they become so big that you could not swallow them. So when you get that sort of maximum caplet size that you often see with calcium tablets, because the carbonate molecule is very small, you can get much more elemental calcium attached to that. With citrate, it's a very large molecule, so there's only limited room for calcium to be attached. So there's much less of a yield of calcium in the tablet. Now, as we're going to see down the road, when you have calcium carbonate on an empty stomach versus calcium citrate on an empty stomach, the calcium citrate absorption is far better than that of the carbonate. But you shouldn't be having calcium on an empty stomach. When you have those supplements on with a meal, the absorption of calcium from calcium carbonate is equally as good as the absorption of calcium from calcium citrate or calcium malate or calcium lactate or all the other different forms that I'm going to show you. So the most cost-effective calcium is actually calcium carbonate as well. So a lot of alternative health practitioners, for some reason, have some kind of negative view of calcium carbonate. They've been told it doesn't dissolve and it just stays as a stone in the large intestine, but that's actually not true. And we'll see those studies. In most healthy individuals, calcium intakes of up to 2,500 milligrams a day are considered safe, but I really don't like to see more than 2,000 milligrams a day going into somebody. With respect to calcium studies, in postmenopausal women, reviews of over 20 studies have concluded that calcium supplementation can decrease bone loss by about 1% per year. That's a dramatic reduction in bone loss. In a meta-analysis of 13 trials, calcium induced significant mean gains or slowed loss of 0.6% at the forearm, 3% at the spine, 2.6% of the femoral neck. So at all really key points in the body, you're helping to preserve bone density. A more recent meta-analysis found that in 15 trials, calcium changes were 1.66% at the lumbar spine and 1.64% at the hip. Therefore, calcium supplementation has been shown to be effective in retarding bone loss in postmenopausal women. The beneficial effect of calcium intake on bone mass in postmenopausal women may be modified by factors including age, number of years since menopause, baseline calcium intake before supplementation, and possibly physical activity. That makes sense. Calcium supplementation appears to improve the efficacy. It improves the efficacy of anti-resorptive therapy. In other words, these drugs like the bisphosphonate drugs, Didracal and alendronate, it improves even their outcomes for patients on those drugs, and including women and individuals on hormone replacement therapy with respect to their bone density readings. So here are some individual calcium supplement studies that have stood out for me over the years that I thought I would review for you, because I just sort of gave you this overview, the snapshot review of all the clinical trials combined, but sometimes when you look at individual studies, they tell a story. So the study by Holbrook back in 1996, 957 men and women. It was a 13-year follow-up study. That's a long time. Demonstrated that adequate calcium intake may reduce hip fracture incidence by up to 60% for individuals 50 to 79 years of age. That's remarkable. Two respective studies indicate 50 to 80% reduction in fractures may be attainable with calcium intake at ideal ranges. And in 1992, Johnson et al. Demonstrated that providing 1,000 milligrams of calcium citrate malate to one member of each of 70 pairs of identical twins for 3 years resulted in significantly higher bone density at several skeletal sites. So they took identical twins because you say, is osteoporosis a genetic disease or is it a nutrition, environmental, lifestyle disease? They said, well, let's use identical twins. They have identical DNA. Let's give one of the twin pairs calcium at 1,000 milligrams a day, and the other one gets the placebo, or they get nothing. And then we follow them for 3 years, and we see that the twin pair that got the calcium had significantly higher bone density at several skeletal sites just within a 3-year period. Nutrition matters. It's not just about genetics. The study of Loya demonstrated that 1,700 milligrams of calcium carbonate prevented bone loss in women 3 to 6 years postmenopausal. So women who are already in the postmenopausal years taking 1,700 milligrams of calcium carbonate prevented bone loss. Calcium carbonate performed as well as Premarin, or hormone replacement therapy, and outperformed the placebo. So 1,500 to 2,000 milligrams of calcium during that postmenopausal era, from food and supplements combined might be, the most ideal target. So that, it's hard to interpret all this and know exactly what the exact number is, but it's somewhere in there. A 2-year study by Reed demonstrated a 43% reduction in bone loss in postmenopausal women who supplemented with 1,000 milligrams of calcium for 2 years compared to the postmenopausal women receiving the placebo. So the study really adds up. And these people like Dr. Reed, and we're going to see Dr. Dawson Hughes, and some of the other, Dr. Hitz, you're going to see some of these major researchers in this field who have really put together some of the groundbreaking studies, but this is the one that really stood out for me in 2007. In a groundbreaking 2007 2007 double-blind study involving 122 subjects over the age of 50. 84% were postmenopausal women who had sustained already a low energy fracture, energy fracture of the hip or upper extremity. They had already had fractures already. These subjects were assigned to 1,550 milligrams of elemental calcium from calcium carbonate, plus 1,400 IUs of vitamin D, or they got the placebo. And even in the placebo, there was 200 IUs of vitamin D. The bone density of their hips and lumbar spine were taken at baseline and then 12 months after the intervention. Other markers of bone turnover, as well as parathyroid hormone levels, were also evaluated during the study, as well as the timed up-and-go test was also assessed for physical performance. How quickly could they get out of a chair and get walking? So after 12 months, remember these are high-risk people. They've already had a significant fracture. After 12 months of intervention, the group receiving the calcium and vitamin D supplements showed reduced bone turnover and significantly increased their bone mineral density in the lumbar spine. Remember, these are already older individuals who already had fractures. They were able to, without drugs, increase their bone density, especially in the lumbar spine and to a lesser degree the neck of the femur. And the subgroup of those individuals taking supplements who were the most physically active got even the best results in terms of increased bone density and decreased bone turnover. In contrast to the group receiving calcium and vitamin D, subjects in the placebo group showed a decrease in bone density during the same 12-month period, including those who were physically active. So just physical activity alone isn't going to preserve bone enough. You need to get calcium and vitamin D into your body. And so those high-risk individuals who took the placebo, they lost bone over the same period of time, even if they were exercising. Another striking finding of the study pertains to the rise in blood levels of vitamin D. So on average, when they started out, the average level was 33 nanomoles per liter, which is very low. And it went to 85 nanomoles per liter, which is ideal, by just giving the person 1,400 IUs a day for 1 year. So that's not a lot of vitamin D. Most people can get their vitamin D levels into the optimal range in a fairly short period of time with vitamin D supplementation if they're below. And you want to, for osteoporosis, be around that 85 nanomole per liter level or higher. 33 nanomoles per liter is very low. Anything under 50 is considered vitamin D deficiency. Of note is that LM Lab, so this is another study, had previously shown that 1,000 milligrams of vitamin D per day showed a 50 to 60% decrease in cancer incidence. So this was an osteoporosis study undertaken by Lab, published also in the American Journal of Clinical Nutrition in 2007. They were looking to see if they could reduce risk of osteoporosis. In subgroup analysis after the study, they said, not only did it help maintain bone density, but the group that got the vitamin D at just 1,000 IUs a day had a 50 to 60% decreased incidence of cancer. So that's noteworthy as well. So the study by Hitz and followers calls into attention the need for drugs like Fosamax and other drugs to be used in the routine management of osteoporosis, although I'm not really questioning that so much myself. When someone has osteoporosis, I think you have to look at the amount of bone loss and other factors and determine if they are a candidate for anti-resorptive drugs. I think that's a fair thing to be assessing. The safest, most reliable way to prevent bone fractures and osteoporosis at the end of the day comes down to lifestyle basics. Weight-bearing and/or resistance exercise training over your lifetime. A calcium intake as you get older of 1,000 to 1,500 milligrams a day. A vitamin D level that gets you to at least 80 nanomoles per liter, which would be 32 grams per milliliter. And also, you need other bone support nutrients, which we're going to discuss coming up. But here's something to note, and that is that you have to be cautious with vitamin D supplements in patients that have sarcoidosis, hyperparathyroidism, active tuberculosis, or active lymphomas. And so in the case of sarcoidosis and tuberculosis and lymphomas, the macrophages that are part of the granuloma tissue in those diseases actually starts to take vitamin D from the bloodstream and can make a lot of 1,25 dihydroxycholecalciferol. and secretes lots of it into the bloodstream. These people already often have very high levels of vitamin D. And so adding more vitamin D to that individual might actually create vitamin D toxicity. So you have to be careful with those individuals, and also patients with hyperparathyroidism. So always get a baseline vitamin D level on these patients before you start introducing supplements. So with vitamin D and sarcoidosis frequently causes a dysregulation of vitamin D production with an increase in extrarenal production. So you're getting lots of vitamin D, 125 dihydroxycholecalciferol, that's not being made by, normally the kidneys make that, but now it's being made by the macrophages in the granuloma tissue. Specifically, macrophages inside the granulomas convert vitamin D to its active form, resulting in elevated 125 dihydroxycholecalciferol. And symptoms of hypervitamin D-osis would include fatigue, lack of strength and energy, irritability, a metallic taste in the mouth, temporary memory loss, cognitive problems. So that's what the high doses of vitamin D or hypervitamin D in a toxic range in the bloodstream can produce these side effects. So toxicity is when your blood level of vitamin D is above 250 nanomoles per liter as a rule, or about 100 nanograms per milliliter. So where's calcium coming from in foods? You should really have, as a health practitioner, a snapshot of how much calcium you get from certain food servings, the healthier food servings, because that's what you're going to be recommending to people. And understand that some tofu products now are enriched with extra calcium, and even lentils and beans are a fairly good source. So just keep that in mind. But low-fat yogurt is, to me, the gold standard. 1 cup has 415 milligrams of calcium. And remember, in that, there's going to be some lactose in there. It might be fortified with vitamin D. There's very little fiber. There's a whole bunch of ways that it makes that calcium very bioavailable. And low-fat milk in 1 cup, about 300 milligrams. Low-fat cheeses have some. Not all cheeses are fortified, though, with vitamin D, but they're still containing calcium, as you see. The sardines with bones, when you have sardines, I mean, not a lot of people eat sardines on a regular basis, but if you do, you're getting a lot of calcium from those little bones that are in the sardines. The stomach acids can break those bones apart and release the calcium. Same with small little salmon bones. The same thing, you get a generous amount of calcium from salmon. And there's tofu with its calcium sulfate enrichment, just 4 ounces, 145 milligrams, very respectable. And then you see shrimp, you see lentils, 75 milligrams in a cup of lentils. And a lot of beans and peas have, comparable amounts. Maybe not quite as much as lentils do. And then in chicken and tuna, you see there's really not a lot of calcium there. In collard greens, so remember that with vegetables, the high levels of fiber, phytic acid and oxalic acid, can bind, because they have a negative charge, they bind to get calcium and iron, and they decrease the bioavailability of the calcium from those foods. So even though these foods have calcium, the amount of calcium you're going to absorb is going to be significantly less than when you're getting calcium from low-fat yogurt and low-fat cheese and sardines and salmon. But you're still getting calcium absorption. It's just being impaired to some degree, and no one knows exactly to what degree, because it depends on what else is in the stomach at the same time. But it's probably at least a 10% reduction. So if you're absorbing, say, 30% of the calcium from dairy products at age 60, then from vegetables, you're probably absorbing 20 to 25% of that calcium, maybe. But collard greens, 880 milligrams. Spinach has some calcium. Broccoli has calcium. Oranges, green beans, fair amount. Then you get into like lettuce, doesn't have much. Orange juice doesn't have much. An apple, bread, it's enriched with some calcium. Spaghetti, cooked rice, not a lot of if you're relying on this for your calcium, you're in big trouble. Apricots and dates, you see them hovering around this 20 milligram mark for a serving size. Figs have a little more. Grapefruit and oranges, have similar amounts roughly. And then you have prunes and raisins and raspberries and strawberries. They're slightly more than oranges. So it just gives you some idea as to if you're trying to get to 1,000 milligrams of calcium a day, just using a bunch of plant foods, it's not so easy. Milk really contains the gold standard calcium. It's been shown to be highly bioavailable, and you can use that calcium for bone mineral density. So sometimes there's this debate about when you pasteurize milk, how you denature everything and the calcium's not absorbable and you've destroyed all the nutrient content, but that just doesn't hold up under scientific scrutiny. Studies show very clearly that the calcium from dairy products is absorbed extremely well and is used to actually help support bone mineral density. So calcium absorption in the internal environment. So that's what we'll look at when we come back. We'll pick it up there. We'll start to look at the things that influence calcium absorption other than just the amount of calcium in food, because there's a multitude of factors that sort of have an influence that determine what your calcium absorption will be at any particular meal. So when we come back, we'll pick up the story right there.